Are you able to see? Yeah, sorry. So when we started our practice, every doctor is well versed with the clinical aspect, and with all the drugs coming up, we definitely know when to place the drug. But are we able to at the end of the day? So the reason is because a clinic is a teamwork. It's not just because a doctor, he doesn't run the show entirely. It's always about everyone else. So we did a comparative study examining 35 diabetes clinics across East and West India, and we did a systemic operational barriers what each doctor was facing. We enrolled 17 clinics from the West Zone and 18 from the Northeast, from Assam, and when we tried to see what were the issues that each doctor were facing. So the national burden of India has reached the tipping point. 101 million diabetics adults are living with diabetes, and 136 million are adults who are pre-diabetic. And usually the transition is in the same way. The narrowing of urban and rural gap is completely increasing, and tier 3 clinics must become the backbone of care to prevent tertiary collapse. So when we saw the clinic scale East versus West, we saw 59% of the patients were seen, 59% of the doctors were seeing less than 15 patients a day, and almost 15 to 61 patients, 61% of the doctors were managing 15 to 30 patients per day. This disparity indicates the West Zone facilities are operating closer and at a sustainable scale than the East Zone clinics. What was the actual bottleneck? So we tried to figure out the bottleneck, and it was the chief complaint, which was the silent epidemic was of a patient drop-off. The prevalence of more than 20 to 40% of the patient drop-off was seen in almost 64.7% in the East clinics, and it was 52.9% in Western Zone. So almost 1/3 of the patients were lost to follow-up, and we usually retain 35% of the patient. And mind, this is in a tier 3 city which already has less number of diabetes clinics. So we always want to have an ideal diabetic clinic which are specialized center of excellence, which are highly defined, which are localized, and has a large catchment area. But usually the structures are denoted in such a way that it is run by a single person. There are less catchment areas, and the volume is usually very high. So when we understood the impact, the main thing was understaffing. Almost 100% of the West Zone clinics were running understaffed compared to 76.5% in the Northeast or the Eastern Zone. It was because of underqualified staff that we were able to get at a tier 3 clinic. And even there were a higher follow-up default rates. There was almost 20% default rate. In East Zone, less than 20% default rate was seen in 29.4%, and in West it was 35.3%. From 20 to 40% default rate of medicine dropout was seen in 64.7% in East and 52.9% in the West Zone. And over 40% of default rate was seen in almost 5.9% in Eastern, and in West Zone 11.8%. And even the gap of education was seen. Almost 4 to 5 times of the patient usually didn't know what HbA1c was in a tier 3 city, because usually the tier 3 city handle the patients which are far more rural. And similarly, we can see the bottleneck. 20 to 40% of the patient did not adhere to the treatment because of lack of the knowledge. Either it is due to poor literacy or maybe due to cost barriers. So there were multiple barriers. Even digital maturity was also less, and even HbA1c tracking was also less. 23.5% of the patients in the Eastern Zone, they were able to track easily, and in Eastern Zone 35.3% were tracked manually, whereas in East Zone 11.8% they were not able to track their patients in the longer run. In West Zone 33.3% of the patients were easily tracked, and in West manual effort was required in 44.4%. So the record or the EMR based structure was far more prevalent in the Western Zone than in the Eastern Zone. And recall system was also very much fragmented. There was no system in 23.5% in both zones, and they relied purely when patient comes in, and then they check whether the patient came previously or not. And 50% of the manual recall is dependent upon the staff memory, and EMR based was only present in 23.5%, and automated reminder systems were only in 23.5% patient, which was due to the EMR that they had. And also there was affordability crisis as well, because there was lack of bundled care, because we didn't have packages in our we didn't have pharmacy at many of the places, and because the patient were unable to get to the place, many of the patients suffered dropout of medicine. So this is how a tier 3 center of excellence should look like. Once the patient enters, the patient should go to the lab technician first, where the POCT testing should be done. Then the patient should go to a dietitian or a diabetes educator, then to the consultant room, and then to the pharmacy, and the patient should exit in such a way. So this should be the flow rate. This should be the flow of a patient when it comes to a diabetes clinic. But usually it is not seen, because my own clinic, it's only 300 square feet. How can I fit all these things in a 300 square feet area? When I learned diabetes, it was at under Dr. V. Mohan, and he had a huge setup of almost 4 floors. It looks very good when we see that we are able to do this, but I am not able to replicate it, and thus this question arises, that is it just me that I am not able to do, or it is throughout everywhere? So this system, this thing arises in every tier 3 city. We are not able to get proper staff, we are not able to get proper place, we are not able to get proper things that should be done. So eventually, maybe in the longer run, we will be able to get it. There are definitely economic barriers. Patients skip test because of because of lack of affordability. Because of that, the treatment outcome suffers, and eventually we have to modify our prescriptions. So what we finally found was that there was a patient literacy gap. 53% of the clinics reported poor HbA1c understanding among the patients. There was scalability challenge, because 59% of the clinics, they operated on low daily footfall, and there was definitely affordability stress. In the West Zone, we have seen that 100% of the doctors, they reported understaffed. They were understaffed or had less number of qualified staff. There was scaling challenge, because after a certain point, they were not able to manage the similar amount of patient. And also there was a lot of follow-up leakages. And follow-up leakages was not because of the thing that patient are not coming. Most of the time it was lack of education and clinical inertia as well, because the patient thinks that they have to take the same medication over and over. That is why. So what should be done? We have to automate the process. It is a team-based care model, and everything should be EMR enabled. So strengthening tier 3 clinics is no longer an optional upgrade. It is an operational necessity. Without this, restructuring Indian healthcare system risks collapsing under weight of rural diabetes transition. So there was a dialogue in शोले, जब गीदड़ की मौत आती है तब वो शहर की तरफ भागता है, लेकिन शहर में ही अच्छे डायबिटीज़ क्लिनिक्स अभी नहीं है तो वो कहाँ जाएगा? थैंक यू.